patient walks into your clinic. You sit them down, and their visual field printout is handed to you. It looks like a page of random numbers, a scattering of black squares and confusing probability symbols. It can be, well, incredibly intimidating. But hidden somewhere on that page is the answer to one absolutely crucial question. Is this glaucoma, cataract, a neurological disease, or simply just a really bad test?
So take a look. Can you spot the diagnosis? I mean, which one is normal and which one is actually glaucoma? Welcome to this explainer. I am so excited to guide you through this today because by the time we wrap up, you're going to know exactly how to break down a visual field printout step by step, just like an experienced clinician.
So here's our roadmap for today. First, the glaucoma detective. Second, mechanisms and classic defects. Third, trusting the visual field. Fourth, global indices made easy. Fifth, probability maps and GHT. And finally, the 5-step method. We've got a really solid structure to our investigation, so let's just dive right in.
Section 1. The Glaucoma Detective.
Diagnosing glaucoma is exactly like solving a crime, you know? One single clue is never enough. We use a diagnostic triad: intraocular pressure, optic nerve head assessment, and perimetry. Let's look at the actual definition of glaucoma, because right here lies a massive exam trap. Glaucoma is defined as an optic neuropathy causing characteristic optic nerve head cupping and visual field loss. Did you catch that? Notice how the definition of glaucoma doesn't actually mention intraocular pressure anywhere? Sure, we have high-tension glaucoma and ocular hypertension, but we also see normal tension and even low-tension glaucoma. Pressure is just a risk factor, guys. It's not the entire disease.
Moving on to Section 2, Mechanisms and Classic Defects.
When it comes to why this damage actually happens, it really comes down to a battle of two theories. In the red corner, we have Team Mechanical Theory. They argue that abnormal IOP directly damages the optic nerve by compressing the sclerolaminar sheets. It's literally pinching the ganglion cells and leading to cell death. But, well, that doesn't really explain normal tension glaucoma, does it? So enter Team Vascular Theory. They argue that a decrease in blood flow in the sclerolaminocribrosa damages the nerve through ischemia. So, what's the truth? True glaucomatous damage is almost certainly a combination of both mechanical and vascular factors working together.
And this brilliantly illustrates the visual patterns that result from that specific damage. These are the patterns you need to be able to recognize instantly. On the left, check out that plastic nasal step and a paracentral scotoma. Now look on the right. Look at that dense arcuate scotoma. It follows the retinal nerve fiber layer perfectly, curving around like this giant banana-shaped shadow. You'll also want to keep an eye out for an enlargement of the blind spot. Remember, the inferior nasal area of the optic nerve is the most vulnerable to mechanical damage, which is exactly why we so often see these defects mapping to those specific nerve fiber pathways.
All right, Section 3, Trusting the Visual Field.
Listen, before you look at a single visual defect, you absolutely must establish reliability. I want you to drill these specific exam thresholds into your memory right now. A field is clinically unreliable if fixation losses are greater than 20%, or if false positives or false negatives are greater than 33%. You must never, ever diagnose glaucoma before verifying if the field is actually reliable. A trigger-happy patient with high false positives is going to completely mask a true defect. You can find these vital clues right here, situated neatly at the top left of the printout. Always make this your very first glance when a printout is handed to you in clinic.
Okay, so once you've confirmed reliability, your eyes are naturally going to want to wander down to the dark, scary shadows on the page. But I want you to remember this punchy little maxim. The grayscale is where beginners look first and experts look last.
Here's the deal. The crucial point is that the grayscale is really just a graphical representation of the numeric printout. Sure, it gives a really quick, useful visual representation of light sensitivity, but relying on it alone to make a diagnosis, highly dangerous. It can exaggerate minor fluctuations and completely hide subtle but statistically significant early glaucoma. Use it for a quick glance, for sure, but never rest your case on it.
Section 4. Global Indices Made Easy.
Here is a totally memorable clinician rule to anchor these definitions in your mind. Mean deviation, or MD, tells you that something is wrong. It measures diffuse loss, meaning the overall average sensitivity compared to a normal population. Pattern standard deviation, or PSD, on the other hand, tells you something is wrong somewhere. It measures focal loss, and it is highly sensitive to the non-uniformity that glaucoma absolutely loves to cause.
You'll find these values right here on the right-hand side of the printout. Now, here's a quick exam tip for you. Older machines used to calculate short-term fluctuation, or SF, and corrected pattern standard deviation, or CPSD. But modern CETA testing strategies don't actually calculate SF anymore, and therefore they don't give you CPSD either. So don't sweat those. Just focus your energy on mastering MD and PSD.
Section 5. Probability Maps and GHT.
I like to think of the patient's visual field kind of like a hill of vision. The total deviation map shows you the absolute difference from normal. It's highly sensitive to things like cataracts, which lower the entire hill of vision diffusely. The pattern deviation map, however, that is your true glaucoma hunter. It mathematically strips away the overall height of the hill, filtering out the cataract entirely, to look exclusively for localized, focal potholes.
Now, what's really fascinating here is how these maps turn those visual potholes into hard, actionable data. If a threshold value falls outside a given normal population confidence interval, it gets assigned a probability symbol. The darker the square, the more statistically significant and abnormal that specific point is. It literally takes the guesswork completely out of the grayscale.
Right next to these maps, you have the glaucoma hemifield test, or GHT. The GHT is essentially acting as your symmetry detective. Because the retinal nerve fibers run in distinct upper and lower bundles, glaucoma usually damages them asymmetrically. The GHT directly compares the upper visual field sectors with their exact mirror images in the lower visual field to flag this classic glaucomatous asymmetry. It will clearly state if it's within normal limits, borderline outside normal limits, or if there's a general reduction or abnormally high sensitivity.
Section 6. The 5-step method.
Let's see how all this builds into our ultimate 5-step interrogation. Step 1, trust. Always check the reliability indices first. Step 2, pattern. Give the grayscale a quick glance. Step 3, indices. Check your MD for diffuse loss and your PSD for focal loss. Step 4, maps. Look straight at your pattern deviation for those hidden potholes. And step 5, GHT. Check for asymmetrical nerve fiber damage. Once you've answered these 5 questions, boom, you are ready to make your diagnosis.
Let's put this into practice with a quick interactive quiz using a real clinical printout. Take a look at this data and apply our 5-step framework. Notice the indices on the right. The mean deviation is significantly flagged at negative 8.71 decibels. That means there is quite a bit of diffuse loss. But look right below it. The pattern standard deviation is incredibly low, just 1.67 decibels, and it's not even flagged as abnormal. The total deviation map has black squares everywhere, but the pattern deviation map is almost entirely clear.
So based on the clues you've just analyzed, a depressed MD but a totally normal PSD, with clear pattern deviation maps, what is your clinical decision? Is this glaucoma? Would you discharge or monitor? Take a second to lock in your answer.
If you said cataract, you hit the nail on the head. The high negative MD and totally normal PSD indicates diffuse loss with zero focal glaucomatous potholes. It's literally just a cataract bringing down that whole hill of vision. As a final thought, always remember the learning effect. A patient's visual field often magically improves on their second or third attempt simply because they learn how to do the test better. But true glaucoma doesn't magically cure itself on repeat tests. If the defect goes away, it was never glaucoma in the first place. Use these 5 steps, trust the probability data over the grayscale shadows, and you'll never be fooled in clinic again. So the next time you're handed a terrifying wall of numbers, will you be ready to crack the case?